Okay, just for the sake of the record, I would say that there are as many studies demonstrating emotional negative effects of distress with amnesia, intraoperative distress followed by explicit amnesia, as there are the studies to show neurotoxicity.
Well, I think that's a matter of opinion, but
Yeah.
that would be a nice review to undertake.
Yeah. Okay. Right.
So I have a couple of questions.
Yeah.
So I have tremendous respect for your anesthesia perspectives, although I don't agree with the endpoints. So, are you an intravenous? Do you are generally TIVA person?
No, not necessarily.
Because what you gave when I was in training, I was in an inhalational school with Joe Artuzio, and the way he taught us was intravenous, neural TIVA. All had the definitions of anesthesia, the components you just said, whereas inhalational was persistent unconsciousness, optional muscle relaxation, analgesia. And before, recently, there wasn't a knowledge of, well, let me ask you, so deep anesthesia in your early stage of your career, was there as much data about concerns of postoperative cognitive dysfunction and other morbid events?
Well, absolutely not. I think this is the whole point in the last couple of decades, is that what we do intraoperatively may in fact have significant effects postoperatively.
Okay.
At the time, like as you mentioned correctly, we just focused on intraoperative events, and once the patient got to the recovery room, we just sort of signed off the case.
Right, and that's important. I wanted to bring that out because it's easy to make the two definitions of an adequate anesthetic look controversial. Like you say, the idea of oblivion is no one would argue against it unless you had safety issues, which is what your concern is. So I just wanted to bring that out.
Right. And I think another difficulty we have with this whole field, the field of controversy, is we use terms that are not necessarily neutral, and that general public, people who are not medical, have much different interpretations. And that's why when we're doing these studies on the IFT, for instance, I much prefer the term responsiveness, because we're not exactly sure what that state represents. Okay. Once you say consciousness or awake, well, obviously that's buying into a whole concept of what awakened consciousness is. Yeah. And what we're talking about is responsiveness in the presence of anesthetic drugs, and we don't know what the implications of that state are. Right. And I think what we need to do is, now that we've identified the IFT as a reproducible phenomenon, generally in anybody's hands, with a recent multi-center study, that we need to follow up to find out what the implications of a positive IFT are, and I think that will inform us a lot more about how to manage the anesthetic.
When you're in the operating room giving an anesthetic yourself, and let's assume that your case doesn't involve neuromuscular blockade, what would you make of movement on the table? What would you make if the patient began to move?
Well, I think, again, as I say, there's no objective measure of how we titrate our medications. I would say that movement intraoperatively is not an unfrequent occurrence. It occurs from time to time. I have no set algorithm for what to do when movement occurs. What I do is take into account everything that's going on and has led up to that point, and I may deepen the anesthetic. I may do nothing. I may give more analgesic. It all depends on sort of the whole framework of what's going on at the time, the context.
Does it indicate lightening of the anesthetic state?
Not necessarily. Okay. Not necessarily. And when you say lightening of anesthetic state, as I said, there are multiple components. So it could be inadequate analgesia. Maybe the surgeon needs to use more local anesthetic, for instance. There may be some extremely painful but short-lived moments. If I can predict those ahead of time that are predictable, then I can give some medication up front before the stimulus. But if the patient moves at that time, I know the stimulus is basically over.
Right.
And why would I deepen the anesthetic at that point?
Okay. Right.
So I just want to point out it's a multifactorial issue.
Yeah, understand. You mentioned the isolated forearm technique. As things stand in the United States, it's really not possible, as I understand it, for an anesthesiologist to use the isolated forearm because the FDA does not approve it. Do you think that the American anesthesiologists such as yourself should be putting the case to the FDA for the use of the isolated forearm technique?
Well, I must say I'm a bit uninformed about the FDA regulation. As I understand it, the FDA regulates drugs and devices. The isolated forearm technique is just using devices that we already use and drugs that we already use. So I'm not sure what the role of the FDA is in terms of regulation regarding the isolated forearm technique. But I would welcome studies to support any sort of FDA application that may be required, because I think that goes along with my previous comment that I think what we need to do is define what the IFT really means, what the implications are, and it would be very nice to see some outcome data post-operatively relating to the IFT.
Okay. That's a great response and music to my ears. I've had responses from other American anesthesiologists to the effect that I can't use the isolated forearm technique because the FDA won't allow me to. It sounds like that's probably just an excuse.
Yes,
I mean, you're absolutely right. I mean, the use of tourniquets or pneumatic tourniquets in theatre has been going on for donkey's years, and we know that the orthopedic surgeons are using, pneumatic blocks all the time and for several hours on end. So clearly there isn't an issue, a safety issue. So that's interesting. Final question. What do you make of the comparison between intraoperative trauma in the presence of amnesic medication and the comparison with date rape? Do you think that's just plain offensive, or do you think there is something in that comparison to be discussed?
Well, I think I'm not actually don't regard it as a comparison.
Right.
What I feel is useful from the date rape publications is the extreme power of amnestic drugs at low doses to really obliterate, to use your words, obliterate memory for even very traumatic events. I think people can relate to the degree of emotional trauma with date rape much better than, for instance, undergoing a bronchoscopy. So that's why I have mentioned that in my previous publications. It's just really illustrative of the power of amnestic drugs, that you can, in a sense, overdose without much downside.
A couple of things about that. I mean, it seems to me that I have, you may know, in the past presented at the MAA meetings making that comparison, and I've come in for quite a lot of flack for that. And I think the reason why some anesthesiologists find it offensive is because they're getting hooked up on the intentions of the perpetrator of date rape, comparing that with the intentions of the anesthesiologist, which of course there is no comparison.
Exactly.
Of course I understand that.
Exactly.
But the central point is that in both situations you have an individual who is experiencing trauma, and trauma for which they haven't actually consented. That's a really important point, consent. Would you approach your patients and say, oh, by the way, you probably will be in distress and pain, but afterwards you will have no anesthetic. The sign here on the dotted line. Probably you wouldn't do that.
Well,
and probably
actually,
no patients would agree to it.
I think it certainly depends how you explain the procedure.
Yeah, yeah.
I think a good example is awake craniotomies.
Yeah, sure.
You can present awake craniotomies as the therapeutic procedure they are, or you could discuss them as a scene from a Hannibal Lecter movie.
Yeah, but they aren't invariably distressing to the patient during the procedure.
Right, right, because there's a whole set of patient expectations and understanding.
Yeah, sure.
And I think the tricky point is how do we talk to our patients about the possibility of a rare event of awareness after the surgery.
Yeah.
One thing I don't want to do is frighten the patient 2 minutes before they go into the operating theater.
Yeah.
Actually, JD gave a sort of a nice script of how we might approach that in terms of dealing with the patients.
Yeah, yeah. Just one other point about the date rape literature. You've mentioned the literature in relation to date rape, not in relation to anesthesia. One of the things the literature in date rape tells us is that you get breakthrough memory. So patients who've been date raped are not simply wandering around in a state of blithe lack of knowledge and awareness. Things suddenly intrude. And I've called this implicit emotional memory. And I've argued that we would expect to see the same things happening in relation to general anesthesia, in which the patient becomes conscious and distressed but subsequently has explicit amnesia. So given the fact that that literature suggests that that kind of breakthrough memory and distress, because it is always distressing, occurs within date rape, don't you think that that means that there are big questions to ask about amnesia in general anesthesia?
Well, I agree with you, there are big questions to ask. I think, as you pointed out earlier, the two situations are completely different. The date rape literature is certainly an uncontrolled life event that has many more factors involved than, let's say, the intraoperative anesthetic.
Sure.
And I'm not sure of the implications of explicit amnesia with emotional trauma occurring intraoperatively. I think there's very little literature on that. What I do know for sure is that if an event occurs, it's much better not to remember it than it is to remember it fully. I think the other issue is how we deal with patients when these memories come up.
Yeah, I mean, we know that a drug like propofol is extremely good at not only ablating explicit recall but also implicit recall, which is helpful. But we also know that the benzodiazepines are very good at ablating explicit recall but not implicit recall. And of course the date rape scenarios are largely of the benzodiazepine category. And what we're seeing is breakthrough memory that is coming from the implicit memory system from a psychological perspective. And what I would put to you is that in my own clinical practice and experience, which involves seeing the results of what anesthesiologists do, is I do see breakthrough memory. I do see implicit emotional memory difficulties that have arisen as a result of episodes of consciousness intraoperatively.
Well, certainly. And I think the literature you're referring to in terms of propofol and midazolam are all single drug studies that are well controlled. I think the situation intraoperatively is quite different. There are many drugs involved. The implicit assumption, pardon the pun, is that if we ablate explicit memory, we're not ablating implicit memory. But if we give more medication, that will then ablate the implicit memory. But we don't know that.
No.
There's no evidence one way or the other. In fact, we know that during anesthesia, sensory perception is intact. Sensory perception is intact. That's why they can do neurological testing during surgery. That the sensory information gets into the brain, and we certainly wouldn't want to ablate that with deeper levels of anesthesia. I think it's a difficult area to study, but I think we should tackle that area. For instance, the implicit memory system may be active all the time, as far as we know, under anesthesia, no matter what sort of depth of anesthesia we're doing, and that maybe other drugs targeting the aversive emotional memory system, for instance, beta blockers, might be the prescription for that rather than deepening anesthesia. So I think it's a complex question, and there's really no data to guide clinical practice at this point to really prevent that emotional breakthrough. What I would really hope is to have a person like you available in our practice, and that we follow our patients more closely post-operatively to pick up these problems early and intervene with the patient. Those patients sort of drop off the map after we have some degree of follow-up, but no way of capturing and identifying these patients that may have these problems to intervene early.
Yeah. Okay.